Good morning. It's a real pleasure for me to be able to participate in the trials and tribulations of various pathologists, and my topic is going to be muscle-bound and plastic. Well, unfortunately, I do have a disclosure, and that is I get book royalties, and here I am with your president from many years ago when we both looked a little bit different than we do today. So, of course, starting off just with an icebreaker question, which country produces the most wine in the world? And I've given 5 selections, so I'll give you a few moments to come up with what you think the answer may be. And in the interest of time, well, if you think about it, the US is the biggest consumer, Spain is the largest area under vine, France exports the most wine, but Italy produces the most wine in the world. So let's talk about salivary gland tumors instead. When you think about it, it represents an incredibly small number of the overall volume. And here you can see it is truly 0.006% of all surgical pathology cases in a large practice. So it really is a very small number, about 8.5 tumors per 100,000 patient years. And specifically, this is both benign and malignant. So they really are very, very uncommon. As you know, fine needle aspiration is the line of first management for most of these lesions, although I'm not really going to go into the cytology findings today. Molecular techniques have kind of caught up over the last several years. So if you looked at what was originally described with Pleomorphic Adenoma, Myoepithelial-myoepithelial, Adenoid, cystic, and secretory carcinoma, now that can be expanded and filled in with both several single point mutations, fusions, and rearrangements identified in many of these particular tumors, and some of them are quite specific for the lesion in which they are identified. So we really have moved forward. Let me talk just a little bit about tumor site distribution, because I do think that this is significant as well. And if you think about major and minor salivary gland distributions, you can see that really more than 85% of the tumors involve major salivary gland sites, and therefore that is the most common location. If you just look in minor salivary gland sites, again, palate is the most common with a more even distribution between other anatomic sites. And then if you think about diagnoses, 52% of all tumors are represented by pleomorphic adenoma when you look at major salivary gland lesions. And so if you think about all tumors in this location, 76% of the tumors are actually benign when occurring in the major salivary gland. Now, let me flip that and go to minor salivary glands. Again, pleomorphic adenoma is still the single most frequent diagnosis. But now, if you look at all of the other tumor types in this category, you will see that now more than 50% of the tumors are malignant. So it is important when you think about a general rule, the smaller the involved salivary gland, the higher the possibility of the tumor being a malignant lesion. When I think about some of the things separating benign and malignant, rate of growth, relationship to the surrounding tissues, circumscription, and cytologic atypia are certainly used in other anatomic sites, but of course, in this location, it may be a little bit more challenging. So, many of these have core needle biopsies, and I think if you looked at this core needle, you would be able to recognize it as an adenoid cystic carcinoma. However, if you had any question at all, looking at the radiographic findings like this, you would know that this cannot possibly be a benign tumor. So I do think that in the head and neck lesions, especially, looking at the radiology is part of your gross interpretation. Well, the World Health Organization has just come out with a new classification, so it's always nice to put things in perspective. And here, if you look at the group of us from 2003, standing outside the facility in Lyon, France, then we went indoors because it was in the middle of winter for the 2016 and then 2017 publication. And alas, because of COVID, Zoom meetings took over. And here we all were on our Zoom meeting coming up with the classification for this next 5th edition. So if you look at it, they're divided out into benign epithelial tumors, mesenchymal tumors that are specific to the salivary gland, and then, of course, the malignant salivary gland lesions. Well, as you can see, 42, 45, and now down to 36 diagnoses. So it's because we have harmonized across all of the organ sites and removed some of the things that were repetitious and therefore have only been presented once in the book rather than being presented multiple times. Well, let me just drive a little bit of the new World Health Organization classification site. You can actually go to tumorclassification.iarc.who in order to be able to find it. Here you can see, I'll just show you a little bit about the head and neck book, where, it has gone through all of the anatomic sites: nasal cavity, nasopharynx, larynx, salivary gland, oral cavity, oropharynx, odontogenic ear, and then the general groups that cover all of the areas. So let me just show you a little bit about one of them. I'll highlight branchioma since that's a new entity for this book. So first of all, if you look down the far left-hand side, you will see that there are multiple different areas where you can click on that particular category, and it would take you to that section within the book and allow you to be able to see that portion. However, when you think about it, definitions, coding, related terms, subtypes, localization, clinical features, epidemiology, etiology, pathogenesis, macroscopic and microscopic features, including histology with cytology, and then essential diagnostic criteria with staging. So as you look at this, you will notice that there are all of these squiggly brackets. Well, if you click on one of those squiggly brackets, it takes you directly through to the PubMed reference that is being cited, which allows you to now go and look at the source material yourself. And here you're actually able to even download the manuscript and go and read the entire article yourself. So I do think that this supporting documentation of where that information is coming from and why it is significant is really very helpful as you review the findings within the book. Of course, the images are also important. Here you can see if you just click on it, you're able to actually go and look at the entire image in a much larger format. Who cares about the radiology, right? So let me show you a histology image instead. And here you can see again that if you open that particular histology image, you're able to actually see a full image size. I think one of the most important things, though, in this book is actually the uploading for every single entity of a whole slide image. So here, if you go and view the whole slide image, you can see that here is a case that has been submitted and vetted by the various members of the authoring team to be able to tell you that this is what they view to be a classic example of this particular category. So here, as an example of a branchioma, you're actually able to go and look at the case yourself and really get a good sense of exactly what it is that you would be able to see in this entity yourself, kind of wallpaper matching, if you will. So I do believe that the entire World Health Organization classification series will have this throughout, and I can assure you that they are there in all of the head and neck areas. One of the other collaborations was with the International Cancer Collaboration Reporting System, ICCR. And so here is an example of a data set that is required for reporting guidelines, free of charge to anyone around the world. And so if you ever have any questions and don't want to spend the time going through the CAP protocols, you certainly can look at one of these as an alternative. Well, let's get to the meat of the matter now, and that is talking about a case. 64-year-old female with asymmetry, 2.4 centimeter lesion identified, and after a fine needle, a parotidectomy was performed. Well, here you can see a lesion affecting the parotid gland. It is obviously quite sizable, and you can see that it is resulting in swelling and expansion of that space. So let's go and drive this particular case now. And here you can see that there is a very well developed multinodular appearance to it. This is a bit far out, though. You know, as you follow the contour of the lesion, this seems to be a little bit further out than what I would like to see. So let's go and look at some of the cellular patterns. First of all, I think you can see that it is kind of a reticulated pattern, if you will, multiple areas showing kind of a myxoid background matrix material present over here, kind of edematous and loose. You can notice that there is sort of a cleared cytoplasm to some of the cells, while other cells show a little bit more eosinophilic cytoplasm, a columnar appearance here, more of a cuboidal appearance over there. And as you look around, maybe even a bit of a spindle cell population over here with that cytoplasmic clearing, as I've already noted previously here, the cytoplasmic clearing is actually quite remarkable. Well, you know, when I look at a case like this, it brings up a very broad differential diagnosis. And in this particular case, this happens to be a myoepithelial-rich proliferation. And so when I think about myoepithelial-rich lesions, these are the ones where I have made the most mistakes in the past. And so I have thought, let me just put together a kind of grid approach to this, and I'm going to show you very quickly over the next 40 minutes a 16-part differential diagnosis. So first, let me just say that when you look at the immunohistochemistry, you have got to do a panel approach in order to be able to survive this entity and these lesions. So here you will notice, if I just highlight the things that are common amongst all of them, you can see that if you do a panel of epithelial markers, CK-pan, P40, P63, CK56, and CK14, along with myoepithelial markers, which again, the P40, P63, CK56, and CK14 are going to encompass along with S100, SOX10, smooth muscle actin, calponin, and GFAP. Now, the reason for that is there's often quite a bit of lineage infidelity and inconsistent reactivity. And so when you are going to do these, you may need to have done several epithelial and myoepithelial markers in order to be able to have something that is going to be positive in the neoplastic setting. Well, let's start off with pleomorphic adenoma. Well, it's always nice to put things in context. So here is a fantastic painting from the Vatican and by Raffaello called The School of Athens. And you'll notice this is set in two different parts. Let's look at the right-hand side on closer power. And you may say, what on earth does this have to do with salivary gland pathology? Well, I'm going to show you this dude up here in the upper left-hand corner. Let's look at him a little bit more closely. Here is a guy with a salivary gland tumor. Can you just imagine? Way back in the 1500s, pleomorphic adenoma was still present. And so it is the most common salivary gland neoplasm, and so you must consider it every time. Of course, it's circumscribed but multinodular with pseudopodal extensions that go outward, as you can see on these two gross specimens where you do have multiple nodules adjacent to the lesion. When you look at it histologically, those same features can be seen, and therefore it is important to recognize that growth pattern. When it is in the clinically recurrent setting, you will have multiple nodules all over, and this can be a mimic of malignancy, both clinically as well as histologically. Well, pleomorphic, right? So you will have a remarkable cellularity, solid, tubular, trabecular, multiple different patterns, spindled epithelial, glandular, and plasmacytoid cells showing a biphasic presentation. And I think that's one of the most important things to remember, that it is a biphasic presentation of epithelial and myoepithelial markers. Also remember that squamous metaplasia is a common finding, as are a variety of other metaplastic phenomenon. So this is kind of the quintessential appearance of that chondromyxoid matrix material blending imperceptibly with the epithelial and myoepithelial elements, also showing areas of glandular differentiation over here. Blending between them, sometimes a little bit more cellular and more glandular than other areas. Nice area of squamous metaplasia blending beautifully with the myoepithelial proliferation adjacent. Now, sometimes it can take on a more myoepithelial-rich appearance. We usually call this a cellular pleomorphic adenoma. And here you can tell that it is predominantly the myoepithelial population. And in fact, when you go to minor salivary gland locations, and specifically in the palate, this plasmacytoid architecture exclusively is probably one of the most common things that you will find in pleomorphic adenoma of that location. Again, you can see a biphasic presentation, so there's a much stronger and heavier deposition in the epithelial compartment with the keratins, while a much more light to non-existent reactivity with keratins in the other population. S100 protein, of course, and GFAP seen in these particular lesions as well. Let's go on now to oncocytoma. I'm just including it very briefly because it's large epithelioid cells, and sometimes they may be the only finding that you see. But just remember that the oncocytic appearance can be seen in a variety of other salivary gland neoplasms, and when it is exclusively of oncocytic cells is when the term oncocytoma is used. Nodule of oncocytic cells, they are all very monotonous one to another. Varying tinctural qualities can be seen within the neoplastic cells. Sometimes you will have an outlining of kind of a basal population here, highlighted with a P40 or a P63, but again, just highlighting a secondary population. If EM were done, you would have a very rich presentation of mitochondria within it. Intercalated duct adenoma, well, this isn't usually a lesion that is clinically removed, but I must say I do see them occasionally as the lesion for which the surgery was done. However, it's usually identified concurrently with something else. I will say that it is a proliferation of both cuboidal ductal cells with attenuated myoepithelial cells, and many times incorporating acinic cells, and that is the reason for having the DOG1 highlighting acinic cells within it. So when I look at it, you can see that it is a cuboidal population, very monotonous in its overall appearance. When you look at it, you can see that there is a highlighting of a cuboidal type appearance with myoepithelial cells noted around it. However, you will notice that there are these eosinophilic granules in the cytoplasm of the acinic cells that are often incorporated within it, and those are one of the tip-offs to the diagnosis, where, as you can see now, the DOG1 gives you a very nice membranous type staining pattern. However, CK7, SOX10, and S100 are positive in these elements because, of course, they are an intercalated duct type phenotype. Well, when you talk about soft tissue lesions, there are a whole bunch of different ones that come into the myoepithelial component, and I'm going to go over them very briefly. Let me just say Schwannoma is, of course, very familiar to us. It's when it's the hypocellular variant that it's a bit more difficult, but remember, again, it's only going to be S100 or SOX10 reactive. So nice interlacing fascicles with spindle-shaped cells, very nice interlacing appearance here, a palisade to the nuclei present over here, almost giving you a characteristic verrucae body. But it is in the hypocellular areas like this, where you have an Antony B area, that it perhaps becomes a little bit more challenging to separate from some of the other myoepithelial-rich lesions, especially if it is in a core needle biopsy specimen. Well, of course, either S100 or SOX10 would be exclusively reactive without any of the other markers in this neoplasm. Same thing with leiomyoma. It's interlacing fascicles, often having a blunt-ended appearance with perinuclear vacuolization. And of course, these are only reactive with the actins or muscle markers, while non-reactive with the other type myoepithelial and epithelial markers. So here you can see a bit of a myxoid change in the center of a tumor. Many of the lesions in the head and neck are associated with a vessel, and therefore you will see them scrolling off a vessel, as you can see in this illustration. That cleared cytoplasm is quite characteristic as a perinuclear dot, but of course, myoepithelial-rich lesions can have that same overall appearance. However, here you can see a very nice, strong Desmond reactivity as an exclusive population in this tumor. Well, extraskeletal myxoid chondrosarcoma is one of the uncertain differentiation lesions, although it is associated with NR4A3 gene rearrangement with a variety of different partners. When one thinks about the ENT sites, the orbit, intracranial, and sinonasal tract is much more common, so you aren't really likely to see it in major salivary glands. However, it's a multinodular, hypocellular lobules of this myxoid chondroid matrix material separating out cords and small clusters and complex tubules with a modest amount of eosinophilic cytoplasm around it with a very delicate cytoplasmic processes. So, if I look at this and you remember what I just drove for the case, you can tell that there is some morphologic overlap, right? These very nice reticulated appearance to the population with a myxoid background stromal component. And of course, when you look on high power, you can see that they are kind of a epithelioid type cell present within these areas. Unfortunately, it's a non-specific immunohistochemistry, but specifically, while the S100 and CD117 can be positive or negative, you will notice that the GFAP and muscle markers are absent in this case. Of course, EWSR1 is going to be identified in these tumors by a fish break-apart probe, as illustrated here. Let me go to a question now. Which epithelioid soft tissue tumor primarily affecting the tongue shows the following? And I've given you 5 different choices. S100 protein, co-expression of MDM2 by immunohistochemistry, GLI1 amplification, and of course, 12q 13.1 alterations, and all of the above. Well, whenever you have a question like this, of course, probably all of the above is what you should choose. And this is an example of one of the newly introduced tumors, primarily actually in the head and neck with the GLI1 altered soft tissue tumors. It's a mesenchymal tumor of uncertain histogenesis, although a pericytic type differentiation is considered, with fusions of GLI1 identified in about 2/3 of cases, while the remaining show amplification, sometimes with co-amplification of CDK4, MDM2, or even STAT6, since they are neighboring genes. As you can tell, about 40% occur in the head and neck, although in the head and neck, the tongue is by far and away the most common. They do show a remarkable protrusion into vascular spaces, wide architectural and cytologic features arranged in nests and sheets, small cells, monomorphic round ovoid nuclei with pinpoint nucleoli, and of course the stroma showing this myxoid or hyalinized material. Again, the immunohistochemistry in this is non-specific, so the smooth muscle actin S100 and CD56 are usually seen, however, usually negative for SOX10, GFAP, P63, and some of the other markers. So here's an example of a lesion expanding into a vessel, another example here in a vascular space, showing a very nice area of monotonous neoplastic cells with small nucleoli. However, I will point out that you have a mitotic figure in 3 separate foci in this single high power field. A rich vascularity is quite commonly seen. Here you will notice more of that Zellbollen type architectural appearance. And here again, a rich vascularity separating out these areas with a loose myxoid stroma. So again, you may have amplification of GLI1 or a rearrangement of GLI1. Either of these need to be tested for in order to diagnose it. So this is a tumor defined by its molecular features. Well, let's now go on to squamous cell carcinoma. And in this case, it's primarily the clear cell variant that I'm speaking of in the differential for myoepithelial tumors. And remember, it's going to be a single cell population, usually showing keratinization with a degree of necrosis and high mitotic activity with a variation depending on whether it is keratinizing or not. Usually showing CK-pan, of course. P40, P63, and CK56 are commonly positive, as is CK14. So again, there's going to be some overlap with the immunohistochemical features. So here you can see an area of complete clear cell, and this would be a direct mimic of a myoepithelial type tumor. But as you move around and look at other areas, I think you can see that these areas of abrupt keratinization and keratin pearl formation should help you in coming up with a differential diagnosis of a squamous cell carcinoma. Remember, though, that they can be positive with CK-pan, P40, and CK56, but I'm also going to illustrate CK14 and smooth muscle actin. Both of these can be seen, especially in the spindled or sarcomatoid variant of squamous cell carcinoma. So again, without applying a wide variety of different markers and looking at the overlying surface to see if it is involved, you could potentially miss the diagnosis in these cases. Well, melanoma, when you think about melanoma, it's really a mimic of everything. When it is in the mucosal sites, of course, the idea of is it metastatic or primary, and the identification of either junctional or pagetoid component certainly tells you the primary disease is present. Well, as you know, it has a broad histologic spectrum, and sometimes we refer to this as protean. And so I thought I'd put in a picture of Proteus, the god of change, presenting in multiple different formats. And that's exactly what you see. So I do think that the peritheliomatous pattern of growth for this tumor is quite distinctive and certainly something that can be sought and looked for. But again, you're going to have markers of melanoma present within this particular tumor, while those for muscle differentiation or epithelial differentiation would be absent. Here you can see an area of a junctional activity that is an atypical melanocyte in a squamous metaplastic area of the sinonasal tract. Here you can see that peritheliomatous distribution of a spindle cell population, and I think you can see that there are areas of pigment present within these neoplastic cells, and therefore should be a tip-off to the underlying diagnosis. However, in a case like this, there's a prominence to the nucleolus, but this spindle cell population does not really give you a sense of what the underlying tumor category may be. Sometimes there's remarkable pleomorphism, as you can see here, with prominent nucleoli and apoptotic figures present in the background, again, not giving you a clue to the underlying diagnosis. Well, as you can see, S100 and SOX10 would be positive, but those are also seen in myoepithelial tumors. And so without adding some other markers like HMB45 or PRAME, potentially you would not get to the diagnosis of melanoma without doing a fairly broad immunohistochemical panel. There's also an ICCR reporting document for mucosal melanomas, and I do find this to be quite helpful to remember which particular features need to be reported for head and neck mucosal-based lesions. Plasmacytoma, well, I'm not a hematron, so please forgive me, but it does have a plasmacytoid architecture, which you can see in myoepithelial lesions, but of course this is going to be something of lymphoid derivation. So you would have CD38 or CD79 and CD38 positive, many times showing either a kappa or lambda light chain restriction. So as you can see here, a kind of monotonous to pleomorphic population showing a plasmacytoid architecture, very prominent nucleoli in this particular high power field, a bit more of a Hoff zone noted here with a plasmacytoid architecture and the more characteristic nuclear chromatin distribution. And so, of course, when you think about the immunophenotype here, CD38 and CD79A would both be positive, with this particular case showing a lambda light chain restriction. So again, plasmacytoma needs to at least be considered in the differential with myoepithelial type tumors within the head and neck space. Let's now transition to the salivary gland malignancies as a whole, with adenoid cystic first. And of course, this is a biphasic epithelial and myoepithelial tumor arranged characteristically in a tubular, cribriform solid pattern showing a very characteristic basophilic matrix with reduplicated basement membrane. So again, this is a biphasic presentation. So you'll notice at the bottom I've said biphasic epithelial and myoepithelial markers seen in this particular tumor with very prominent perineural invasion, and of course stromal clefting and reduplicated basement membrane can be quite helpful. So when I look at an area just like this, I think you can see some cribriform architecture with that very nice background myxoid matrix material. But here is that more characteristic glycosaminoglycan type material that takes on a blue tinctural quality with these more peg-shaped nuclei. However, a case like this has a much less ominous appearance to it, but is still part of the adenoid cystic carcinoma pattern, where you can see those myoepithelial cells juxtaposed next to areas of myxoid matrix. However, here you can now see a bit more of the atypia that can be seen and stromal clefting, here very beautifully highlighted, in this case giving you a very nice stromal cleft around each of these epithelial and glandular elements. And of course, multiple nerves are present within this particular field to show the proclivity for perineural invasion. It is a biphasic population, so here you can see SOX10 and smooth muscle actin highlighting the myoepithelial cells, while the P40 is also very nicely highlighting just the myoepithelial cell component, while when you look at the internal component, CD117 and MYB, which is a reflection of what goes on with the translocation, can certainly be identified in these neoplasms as well. Epithelial-myoepithelial carcinoma is characterized by a very specific biphasic tubular structure, tightly coupled inner ductal cells with a very prominent myoepithelial component out in the surrounding area that is usually quite cleared. So that clearing out of the myoepithelial cells is probably the most helpful feature. Again, it is going to be a biphasic representation of the immunophenotypic expression with CK7 and then abluminal expression with any of a variety of myoepithelial markers. Just remember, it is also RAS mutated in several cases and is by far and away one of the most common cancers identified when you're looking at the carcinoma in a carcinoma X pleomorphic adenoma. So when you look at just single high power fields of these tumors, you may say, oh goodness, I don't see a biphasic presentation in this lesion at all. How did you get to that? And I would say, well, you know, you keep looking around and now actually you can begin to see that there is a glandular component over here surrounded by these cleared out cells that are much more the prominent finding on the left-hand side of the screen. And then when you look in low power in another area, I think you can tell the very rich development of that glandular central compartment surrounded by the myoepithelial cleared out cells, as you can see in this field here. Sometimes they can take on an oncocytic quality, as you can see in this illustration, and therefore hides that particular finding. However, when you look now at the immunohistochemistry, here is the CK7 beautifully highlighting all of the central ductal cells. When you look at the myoepithelial compartment, it is only reacting with the smooth muscle actin. Of course, it would be positive with things like GFAP, P40, CK56, etc. But it is still a very prominent and well-developed biphasic representation. So myoepithelial carcinoma is defined by which of the following? An infiltrative growth of a single cell myoepithelial neoplasm, minor salivary gland site, spindled epithelial neoplastic population, strong S100 protein immunoreactivity, and the last choice, EWSR1 rearrangements in most tumors. Well, I'll let you think about that for a few moments, but really, if you think about it, it's the infiltrative growth of a single cell myoepithelial population that defines a myoepithelial carcinoma. And of course, I'm going to include myoepithelioma here in this particular discussion because the only separation between these lesions is the fact that a myoepithelioma lacks invasion, usually does not have any evidence of necrosis, pleomorphism, increased mitotic activity. So truly, the separation between these is that it is an exclusively myoepithelial tumor showing infiltrative growth for a myoepithelial carcinoma while lacking infiltrative growth and tumor necrosis for a myoepithelioma. Well, you cannot use any of the features seen for sex, age, and site, so those really do not help you. And again, remember that myoepithelial carcinoma can be seen in the setting of a carcinoma X pleomorphic adenoma. So already, as I have suggested, there is a remarkable diversity to myoepithelial-based tumors, both from an architectural standpoint as well as from the morphologic appearance. And they can also have a wide variety of different stromal components, myxoid, mucoid, and even hyalinized. And again, noting that this is a single cell proliferation that is both epithelial and myoepithelial, and not all of these markers are going to be seen in all of the cases. And therefore, you do have to do a broad spectrum in order to be able to come up with the correct diagnosis. So let me just show you 3 or 4 images of a myoepithelioma. This is a non-invasive tumor. You can see a very well-defined capsule surrounding it. A nice example here with a more reticulated pattern and open myxoid stromal component. Much easier to identify myxoid compartment here with these interlacing or archipelaginous growth patterns seen in this myoepithelial proliferation. Much more delicate background stroma in this case, and yet here having a plasmacytoid morphology to this myoepithelioma. Here you can see a very prominent blue round cell appearance to this tumor without much in the way of any cytoplasmic extension, and yet this was a monomorphous population of just myoepithelial cells as well. They can take on a delicate appearance like this, where they stream out a little bit more, showing a open to delicate nuclear chromatin. A much more plasmacytoid architecture, and as I already suggested, if you were in the palate, separating this from a pleomorphic adenoma would certainly be most challenging. Well, now we go to myoepithelial carcinoma, and I'm going to show you very quickly about 13 or 14 images just to show you the wide diversity in architecture. Here you can see infiltration out into the adjacent fat, an area showing a myxoid and packeted appearance, a more hyalinized background stromal compartment in this tumor that showed invasion elsewhere, much more open nuclear chromatin with amphiphilic cytoplasm, a more spindle cell population easily identified here, increased mitotic activity with a myxoid stromal component and a spindled compartment, tumor necrosis with now easily identified pleomorphism in this example, much more prominent rhabdoid features in this tumor, where you can tell that it really has a very, very prominent eosinophilic cytoplasm pulled off to one side. A bit more cytologic pleomorphism in this packeted architectural arrangement, increase in mitotic activity, easily identified and giving you a blue round cell appearance, even though it does have that myxoid stromal compartment adjacent. A more plasmacytoid to rhabdoid appearance morphologically in this tumor, while this one shows a very, very prominent rhabdoid appearance to the neoplastic proliferation. Remarkable pleomorphism can sometimes be seen, as noted in this high power field, where there's a mitotic figure as well as very prominent nucleoli. Well, this means that you're going to have a lot of reactivity across the board. So you'll notice this is the first tumor in the category for the immunophenotype, where you can see that it really does react with almost all of the markers that you're doing in your panel, but it is in a single cell population, which I've highlighted on the far right. So INI1 is intact. This is not like the myoepithelial tumors of soft tissue derivation, where frequently INI1 is lost. So pan-cytokeratin, diffuse and strongly reactive, as can be seen with CK7, a very nice reactivity with EMA in the neoplastic cells of this example of a carcinoma. S100 protein gives you both a nuclear and cytoplasmic reactivity of all of the neoplastic cells that can also be duplicated with the SOX10 immunoreactivity in this tumor. CK56, because it can be a myoepithelial type marker, can be seen, as well as P40, strongly identified in the nuclei of this reticulated pattern tumor. Calponin is strongly reactive in this case, and here you can see GFAP as an example of a myoepithelial marker there. So again, you can tell it is a very broad reactivity for those markers. Well, let's now end with hyalinizing clear cell carcinoma, just to round out one of the clear cell patterns of tumors that lacks any other features of salivary gland neoplasms. And in this case, it's actually considered to be kind of a squamoid cell carcinoma variant, because it is showing squamous differentiation in a single cell population. Well, it usually has a very, very prominent perinuclear infiltration with this hyalinized basement membrane-like material, usually easily identified throughout. So if you look at this first, you can say, wow, there's not really much in the way of clear cell population here. But when you go out to the periphery, you can see this very prominent perineural invasion by this clear celled neoplastic population. So some areas show a more opaque cytoplasm, others then show a more cleared cell population, and other areas show an even much better clear cell population with this very rich stromal hyalinization seen throughout. As you would expect, P40 is positive, but the smooth muscle actin is negative. In fact, if you did an S100 or SOX protein, you will see that it nicely highlights the nerves, but of course does not highlight the neoplasm. And so with that, you are able to make the separation, although again, clear cell tumors very frequently will be associated with EWSR1 break apart FISH probe as part of the rearrangement seen with that gene. So I hope that this has been a very rapid overview of the myoepithelial-rich lesions that you come across, recognizing that a broad spectrum of immunophenotypic studies must be performed in order to make the diagnosis. So you may say, what does this have to do with my title? Well, I'm from California, so I have to include Arnie in the photo. And of course, the plastic part comes from Dolly Parton being very different in each of her appearances. And that is to highlight that myoepithelial tumors can show any and a variety of morphologies of their muscle-bound nature, as well as showing the epithelial nature of its plasticity. So the take-home points: myoepithelial tumors must be considered in a broad differential diagnosis. Remember that both epithelial and myoepithelial tumor immunohistochemistry must be performed with specific attention to the location of these areas. Invasion is required for the diagnosis, and remember that molecular studies may aid in the diagnosis in selected cases. Well, with that, I would like to thank you so much for your attention, and I'd be more than happy to take any questions at this time. Have a fantastic day.